Hello everybody, my name's Liz Cooper and I'm a colorectal matron practitioner employed by Sheffield Teaching Hospitals based at the Northern General. The focus of my presentation is about everything that we've talked about. We've heard from managers, we've heard from commissioners, we've heard from patients, and it's about how all that fits into practice and what actually happens within clinics. As Georgia said, patients who've undergone surgery for colorectal cancer that have been curative are referred to nurse-led follow-up. So that's patients who have had surgery and they may or may not have had adjuvant chemotherapy, and then they may have further surgery such as reversal of the ileostomy. They're the cohort of patients that are referred to nurse-led follow-up. So because we're a little bit short of time, I've been advised I've got to cut some of my presentation short. So, survivorship. So as Georgia said, the new pathway commenced September 2011. What that means is that patients who had colon cancer are diagnosed at 2 years, which would be 2013, and patients who had surgery for rectal cancer are discharged at 3 years post treatment, which would be 2014. And we actually went live in April 2014. Georgia, I think, had a similar slide earlier on, but this is the follow-up protocol. So the cohort of patients, the patients who've had curative treatment are then followed up according to this pathway. So patients undergo 3-monthly CEA, and for those of you that aren't familiar with CEA, it's a tumour marker, a blood test that's used to monitor the recurrence or presence of colorectal cancer. So CEA is done 3-monthly, a CT scan is done at 9-monthly and 2 yearly, and a colonoscopy is done at 5 years or immediately following treatment if patients haven't had a completion colonoscopy prior to the treatment. So that's the pathway. Patients are referred to us, it may be as early as, and I hope I get this right, Lisa, it may be as early as 6 weeks or so after the surgery. So patients will have the surgery, they'll see the consultant, and then the consultant will refer them to nurse-led clinic later on, perhaps 12 months, 18 months. Or some patients, the colon cancer patients, we might only get one visit in before they're actually discharged. Just because I've cut it short a bit, I've altered. It's just thrown me off a bit. So the treatment summary. We've heard about the treatment summary from Kevin and Georgia. So the treatment summary, I think the important thing is that the users, the nurse specialists and the nurse practitioners who were going to complete the treatment summary were involved in the creation of it. So that offers ownership. And also it was important to keep the treatment summary to one page and as simple as possible. So that's what a treatment summary looks like. It's got the patient's details up at the top, the date of the diagnosis, the treatment, the care plan. Can't see what that is there, but other things down there as well. And their ongoing pathway and how to refer back into the system as well. So that treatment summary sits on a system called Infoflex, which is an electronic system, and that's completed by data input clerks who put in the cancer, the date of diagnosis, the staging of the cancer and treatment, and then it comes to the nurses to complete the following bit of it. And all that can be accessed through the system that we use called Infoflex. Once that's completed, it's sent to the GP electronically via NHSnet, a secure email system. As well as the GPs receiving a copy of the treatment summary, They also receive, there's quite a few sheets that go at the back of that that relate to late effects, and that's just one of the sheets relating to radiotherapy and the late effects of radiotherapy on bladder, bowel and sexual function. So that goes with the treatment summary to the GP. The patient also gets a copy of the treatment summary and also the late effects as well. So what happens actually in the clinic then? So once the patient's seen the consultant on completion of the treatment, they're referred to the nurse-led clinic. Before patients attend the clinic, a holistic needs assessment tool is posted out to the patient. So that's a paper version. I was really interested to hear about the electronic systems that are in place, and maybe that's something that I can pursue in my own practice. But for the moment, a paper form of a holistic needs assessment is posted out to the patient, and then that's returned, posted back. And we do actually get good compliance with the returning of that holistic needs assessment tool. A care plan is then formulated based on the holistic needs assessment, and again that's all done paper, so it actually involves somebody sitting down, reading through the holistic needs assessment, and then creating the care plan. Once we get that care plan back, once we get the H&A back and the care plans developed, if patients have identified as having quite complex needs, they'll be invited back to clinic sooner than waiting for the appointment that's already been allocated to them. However, many of the issues identified at that stage do relate to post-operative recovery, such as being able to get out and about, pain, discomfort, problems with the wound maybe. So what happens when patients actually get to clinic? So they undergo a physical assessment, a psychological assessment that's based upon the holistic needs. Specific needs are identified and an action care plan is formulated in the clinic. Patients are then signposted to relevant services, and as you heard from Georgia, we've got the Cancer Care Centre in Sheffield that offers a lot of support and can also signpost to different support services. Patients are actively encouraged to attend health and wellbeing events, and at that very, very early stage we do start discussing the discharge date, the patients that you will be discharged in 2 years or 3 years, and we start discussing that and what that involves. So in clinic, the first clinic appointment is allocated as an hour, and I can probably hear the clinicians amongst you take a sharp intake of breath at an hour. But an hour is time well spent really, and that hour can actually save on future clinic appointments. It's important that hour because that's where you start to discuss the care plan in more detail. And often patients are accompanied by the relatives, the partners, and it's important to remember that the relatives are co-survivors as well. They've been through this experience, they've been through this journey, and they'll have a different story to tell. They're often the ones that have kept it all together. They themselves, as well as being a wife or a husband, might be a parent, a grandparent, and they might also be caring for their elderly relatives as well. So that there can be a lot going on for the co-survivor as well as the survivor. It's a chance to talk about fear of recurrence, about relationships, because relationships can change during this time. Somebody can change from being the main wage earner and the main provider to feeling that their role's been altered within the family dynamic. Getting back to normal, and there's much talk of this new normal. Well, patients we talk to, they don't always want to be a new normal. They want to be the same as they were before all this happened. So it's talking through those, through that. And also, I think one of the speakers said this morning, guilty. Sometimes patients feel guilty that they've they've got this far and they're at this curative stage and they're looking to discharge because unfortunately they may have met people along the way or have had people in the family who haven't done as well. So there is a big feeling of guilt sometimes. And all that can easily take an hour. Follow-up appointments after that are usually about 30 minutes. Within those appointments, the follow-up protocol is discussed as well. So that very busy slide showed earlier on, that's discussed about what will happen at different stages and who will have responsibility for that. So it may be that it's within secondary care for the first 2 or 3 years, and after that it'll be clinicians in primary care. We use a motivational interviewing technique within those appointments, and the nurses who run those clinics have all attended motivational interviewing training. But for those of you that aren't familiar with that technique, it's very client-patient orientated. It's about setting goals, and it's a method that encourages changes in behaviour. And the best way I can describe it, I think, is by giving you an example. So somebody might say, I know I should do more exercise, but I haven't got time. So it's about exploring the why haven't you got time, and then setting small goals to achieve some form of exercise. Or it may be, I know I should eat fruit and vegetables, but I can't because. So it's about exploring the because and just setting small goals that they may try and eat more, one more piece of fruit a day. Just achievable goals. And that's very useful, a useful technique to use. So what does all this mean then? So from the nurses who run those clinics, because I must say I'm fortunate enough to work, I represent a team that work very hard to ensure that patients receive the best possible care and that their experience is as good as it can be. So talking about the treatment summary, initially there was a delay in completing some of the information on there. So that delayed the treatment summary getting out to the GP. So Macmillan did pay for some administrative support to enable that backlog, the backlog of data to be completed. What we learnt as well, and what sometimes is a bit challenging within the clinic, is that we've got 3 different pathways in place. So the survivorship pathway is for patients with a Sheffield postcode. And in Sheffield, at Sheffield Teaching Hospitals, we see patients from Rotherham, Barnsley, Doncaster. So those patients continue coming back to the hospital for 5 years. There's also patients who are on the pre-2011 pathway, and then there's the patients on the new pathway. So in clinic, before seeing a patient, it's vital to just quickly kind of get it in your head which pathway they're on. There are some reservations with regard to monitoring of patients on the new pathway once they go out to primary care, and who has responsibility for that and who helps to coordinate that. There's some anxiety from patients, but perhaps not as much as anticipated, because by that point they're equipped with all the tools necessary to empower them to be responsible or to share their own care. So within clinic, patients are prepared for discharge at their initial consultation, so we start talking about that. They're empowered throughout the clinic visits. We encourage positive lifestyle choices, and they're aware of their ongoing follow-up because they have the shared care plan that's a patient-held record. Implementation, just very quickly again. That's it. So the treatment summary is sent via NHSNet. There wasn't an acknowledgement system in place, but we've now got an acknowledgement system in place. There appears to be, within secondary care, sometimes a lack of awareness as to the process for performing CEA, particularly when there's been a rise in the CEA. Where it's a CA not performed, that's not correct. All patients do receive a CA blood test, but it may not always be in line with recommendations, and that's a learning point moving on. And the process for abnormal results is something that we need to just discuss and learn a little bit more about. So I wanted to just finish talking about HNA. There probably is a need for that much earlier in the pathway, but exactly where in the pathway we're not sure. We've tried at diagnosis, but that is an overwhelming time for patients. They're getting a lot of information, life-changing information. The tool that we did use at that point was the distress thermometer that Kevin showed earlier on. So currently they get patients complete an HNA just prior to the first appointment, on completion of treatment, prior to discharge, and as the condition changes. And I've just got one more slide. So what's that meant in secondary care? Well, it means that some of the follow-up slots we've been able to convert to 2-week wait slots so patients can access the system quicker. The clinical nurse specialist time can be redesigned so that patients who are experiencing late effects of treatment can be seen. HNA, when, where and which tool, still ongoing debate about those points, and how to communicate the HNA to primary care. And is the GP the right person? Should it be the support services? And I've been told I've got to finish there, so I'm cutting out.